Our fourth presenter is Dr. Julietta Rodriguez-Guzman from the Pan American Health Organization, where she's a regional advisor on workers and consumers' health. Julietta?
Good afternoon to all. Thank you very much, John, for that kind introduction. I would like, first of all, to thank you for, first, the organizing committee, and of course, Ivan, who recommended me to come, and also Dr. Luis Augusto Galvao, who is our chief of the special program on sustainable development and health equity, where workers' health and other team workers close to workers' health work together. And we are a great team of 9 people trying to do something for good. So let me see if this works. Okay. So the note I got is I was supposed to respond to work-related health needs in the informal sector. So I really struggled to figure this out in a way that it could be practical because, in fact, there are several issues that have changed through the last 20 years since I've been involved initially as a consultant for PAHO and now as a staff officer. So I'm going to go very quickly through WHO and PAHO's milestones that do effectively affect our work. I'm going to talk about making inequities visible to informal workers, and I'm going to talk about the walk walked and put some food for thoughts. And I am going to talk about a little bit, just 3 points about hopes for the future. So this is WHO. We are an international governmental organization, and it has 6 regions, out of which the Pan American Health Organization is the regional office. However, PAHO also belongs to the Inter-American System of Nations. So we are the health authority for the Americas as well, and we wear the 2 hats and try to make the 2 things work together, although sometimes we sort of divert a little bit from the policies from WHO, basically based on the needs of our region. This is a very quick overview since WHO was born back in the 40s, and how its policies for mandatory public health has been moving from primary health care for health for all through the famous reforms and the packages, minimal packages for health, then through the development goals, the Millennium Development Goals, and then it went through Escalade to go to the determinants of health and finally come back to primary health care very quickly in a very quick shot. But we came back to the circle, so we hope that we will go through. Now, PAHO, and this is strictly focused on workers' health, also has been walking with WHO and by itself. As you can see in the slide, I don't know if it has a pointer, so the button at the top, okay. So we started back in the year 1990, and in fact, the first regional advisor on workers' health came to PAHO in 1984. Then he was replaced in 1999, and he worked for PAHO until 1994. I mean, he came into PAHO in 1989, and he worked for 5 years until 1994. The third advisor was Dr. Maritza Tennessee, that probably many of you know. She worked there for 17 years, and now she's retired since 2011. And then I have the privilege of being the 4th one. So, but however, I did walk the walk with Maritza because I was an officer for the Ministry of Health of Colombia, and I was a collaborating center for the network of collaborating centers of WHO. So this is a quick walk through all the things that have happened. In '94, the global strategy of occupational health for all in the Beijing Declaration that was supported by the Collaborating Centers Network, then we started to design and make a work of consensus to develop a regional action plan on workers' health, recognizing that we had very many problems. And then we had our 3rd collaborating centers meeting in Colombia. That's why I put it there. And then in 1999, we had finally the approval of the Directive Council of our plan. And of course, we were very happy to have that plan. And the plan originally had these or has these lines of action and focus on quality of work environments, policy and legislation, national plans and committees, basically focusing on those, and worker self-promotion. Initially, we were talking about healthy workplaces. And finally, a comprehensive health services delivery, tackling on primary health care. Then later, we go up, and then as PAHO evolves in both the collaborating centers network at global level evolves. We have the Stresa Declaration trying to put all collaborating centers with the same focus and aiming for the improvement of workers' health around the world. And that same year, the year before in 2006, we had an evaluation, the first evaluation of our regional action plan. And based on that evaluation, as well as on the a global survey, we had the chance to realize that we needed to adjust our plan. So the second box you see up here responds to those changes. Up there, you see that it's protecting healthcare workers and human resources for health was the big focus. Prevention of occupational diseases, particularly those agreed with with ILO in our joint committee, WHO-ILO. And thirdly, prevention of emergent diseases. In these times, we had H1N1, and this was a big issue because of the Canadian situation, etc. So after that, we had the opportunity to have the approval of the Global Action Plan and WHO. And of course, we had to adjust our work plan to those mandates of WHO. And then it comes this stage where you see above. Basically, what we're doing now is based on the evaluation of these years and what happened before, after Maritza left, was to try to organize what are the real things we need and what are the things we need to protect critical sectors. And as you can see in the slide, informal sector is our number one, and you'll see why. And health sector, because it's the house. We need good health, human resources, and a good health sector delivery. So these are our two priorities. And of course, preventing occupational diseases and NCDs, and comprehensive occupational health services, basically aligned with all what Ivan has said in primary health care, and strengthening occupational health sciences, practice, and education, because we need people to work on this field. So basically, this is a very runner-up of that. So what do we conclude for this? One of the first things that we realize is that the framework, the theoretical approach to workers' health has changed. We are not only talking about risk assessment approach, we're now talking about social determinants of health, and the fact that it was acknowledged the difference and the impact of employment and working conditions by separate did make a difference, so that we can approach this group of conditions also in the informal sector. And then lately, the social and environmental determinants of health at work, which defines a multi-cause, a multi-systemic, and a multi-sectorial approach attached to the mandates of the post-Rio Plus 20 Sustainable Development Goals and the health promotion. And this is relatively new, the health in all policies approach that right now is under study for becoming a regional plan also in the governing bodies. So quickly going to achieve all these 5 lines over the global action plan and to really tackle the informal workforce, we need advocacy, we need policies, we need education, surveillance, training, and research. These are fields that are a must for all of us. And of course, the principles are trying to attain the highest level and the highest standards for health, to promote and protect health, to enhance primary prevention, because it does cure and it saves a lot of money. It's the only way to really cure, to prevent. And using workplace settings for health interventions, particularly for working populations, that mean people from 18 to 65. And you're going to say, where are the children at work? Don't worry, we also look at them. But we're trying to enhance the fact that the work setting is a place where you can find people working and people sick of NCDs. Coordinating responses by the health system, particular settings and economic sectors, and this is a big challenge, focusing on reducing inequities, acting actively with the active participation of workers in grassroots organizations, and then expecting coverage for all workers with all occupational health services. This is what we would love, huh? But we know that the social injustice is killing people, and we would like to follow the MCONET, where my dear friend, ay carambas, Vilma, thank you, had a good chair and help us build all of this, but we want to improve daily living conditions, to tackle the inequities in distribution of power, money, and resources, and to measure and understand the problem, to assess interventions and their impact. This is the really huge, big challenge for the informal work. And of course, with the mandates of the knowledge networks of employment conditions to improve and to achieve decent, healthy, and secure jobs. And you remember this slide from Ivan? I always use it too, because just to remember, so with this change on the framework, we do not only look at this set of working environment based on risk assessment. We have to look to work-related health practices, we have to look to social factors, and we have to look to access to health services. And this has a little adaptation for the Americas, so it is a little bit different than Ivan's, but it's okay. So making inequities visible for the informal workers, let's look at the big portrait to go to the small portrait. Employment rates and population since 2000 for countries with data according to the report that ILO issued last year in the key indicators of labor market, the CLIM, says and shows us that Latin America, in almost all the regions of the globe, particularly the Sub-Saharan Africa, the Southeast Asia, in the South Asia, as well as the East Asia, are basically with the same trends in employment. That means lesser employment if you look at the developing countries and the the European countries, basically, in North America. And as you can see in the slide also, male work prevails over female work. That's no news, but it's good to have it registered, right? And then we have the distribution of employment, and you see the whites in Africa and the whites in Asia. It means very low employment. The darker blues are in North America, in the south corner of South America, in Europe and Australia. Those are the high rates of employment. So it is an inequitable distribution of employment all over the world. And if you look at countries to see how is the employment status in selected countries during the last 2 years, according to this report, then you will see that people in Indonesia have very low wage and salaried workers, while Norway has the highest, together with France and Australia. So you see, again, there is a big gap. And this is what we call the inequities, the big, huge difference between ours. Now we put a little coin in there. The suffering of all regions of the world, this is poverty. What you see in the slide is estimated global workforce with precarious work and poverty by regions. And what you see in the green dots is the poverty rate of $2 per day, and the red dots, the poverty rate of $1.25 per day. And you see how much in each region there are of these people here. So if you understand, I want to focus on the Americas, and you can see also Asia and South Asia and Sub-Saharan Africa. Well, the situation is very critical. But in Latin America, if we have 1 billion persons in the Americas, out of which approximately 500 are workers, and we put this 17 plus 8 together, that's 25% of the region. That means we're talking about 250 million people in precarious work and poverty. So it is a huge challenge. And if you look at this, I know it looks a little hectic. I just advise you, it's from this same report, but just look at the colors. The blue colors is the employment. The red little color is unemployment, and the green is economically active people. And you see that it looks like green. So if you can see, these are all low income and middle income economies. There is no high economies here. But what you see here is a massive amount of people without employment and a lot of people that are supposed to be working, but we don't know where. So this is part of the big coin that adds to the portrait I've shown you. So this is what I just said about the Americas, how we're distributed, so I won't start there. And we're going to look a little bit about the inequities because this is part of what we have to solve for informal workers. And then the first guilt I have to talk about is the economic production as defined in the current systems of national accounts. And if you look at the economical activities, right now, non-productive activities, basic human activities, purely natural processes like studying is not considered a productive activity. And between the productive activities, those that are non-economic production include cleaning, cooking, repairing, caring for others, transporting. So automatically, by the system, we're excluded. So just a little example there. Now, we have, throughout the region, employment conditions that are basically defined by contract, salaries, and social protection with all the plus benefits that we know, maternity leave, sick leave, et cetera, et cetera. While in the working conditions, we have all those hazards derived from nature and processes and risks and hazards. And what we know up until now, after all the things we have done in the region, is that this is very different from country to country and within countries. So we have a very heterogenic region, nothing different than from other regions, nothing different from what everybody has said before, but documenting it is another question. This is the unemployment rates in the 90s for Latin America, the average, and you can see that both the rate of employment and the numbers for unemployment were very similar to each other. And if we look what happened since 2000 until 2011, wow, they're going down. But when the crisis came in 2009, the rates started to pop up again. And theoretically, Latin America is doing much better. Our income is getting better, and we didn't suffer very much. However, how did we grow and how did we sustain not to sink in the crisis? And this is an exercise we did based on the statistical update on employment of the informal economy that ILO published in 2011, and we played with the numbers of the countries. And what you see in this, it looks a little crazy, but it is not that much. The line down here is the rate of unemployment, okay? And it seems everybody's sort of equal, huh? The line in purple is the rate of people participating in the workforce. So we have a lot of people participating in the workforce in all the countries. And you have 16 countries there. And then the persons in the informal sector are the ones in the orange. And persons with informal employment are the ones in red. And you will see that they are almost as high for both. And there are countries that are in critical conditions of both employment and informal employment and work. For example, Bolivia rates over 70. For example, Ecuador rates up to 60. If you look at Peru, it's all the way in 90. So, I mean, this is a very critical portrait. And the rates and the numbers, when you talk about unemployment, hide these realities. So we're sort of hiding the real numbers and the real problem in the adequate quantity. So it is a sustained growth sector. It has great difficulties to be defined, quantified, and characterized. It varies within and within countries. It has a lot of difficulties for copayment for social benefits if they need it, and we have big amounts of populations under vulnerability. We don't talk about any more vulnerable people because it's considered inappropriate. So all of them, women, children, aging adults, indigenous, elderly, and people with disability, all fall in this category of informality. Child labor is a big problem. This is a graph that Oriel Solar helped us do to show you in 16 countries, there is not one that has no lack of child work, very severe. The worst, Peru, Bolivia, and Guatemala. The worst part of it is the silent majority that are in the worst forms of work, and this is domestic work hidden in the private domestic settings, because we cannot go in there, and the agricultural settings. You have seen all the data, and all of them refer to non-agricultural. Rural workers and rural settings seems to be invisible, and this is a huge problem. We have forced labor, and here again, women, children, youngsters, indigenous, and elders. And in the region, it is estimated we have 1.8 million people in those conditions. Women at work, even though they have been the source of improving and increasing the workforce in the region, they continue to have limited working conditions. They continue to have disadvantages in relation to social development. Poverty impedes access for opportunities for education and training. And of course, the portrait is not very happy for them. They still suffer the 6 major occupational health effects that are portrayed in this slide. And of course, since my time is over, I'm going to go very quickly. Violence at work, social security coverage, very weak, very improper, and of course, all the burden of NCDs on top of us is the #1 killer in the region, with cardiovascular diseases and cancer. But we have 145 million of smokers, 139 million of people with overweight, mostly in the lowest ranges of economy, and approximately 250 million living with NCDs in the America. So we know we can solve the problem. Worker conditions are critical all over. This is one of the surveys of the exercise of analyzing surveys that Oriel did, where she shows Argentina, Colombia, Guatemala, Nicaragua, and Chile all have exposures to all kinds of, there is not one type of hazard in the workplace that we don't have exposure. And this is supposed to be to the formal people. We have to assume, based on the inherent risk of work, that informal workers must be the same or worse. And of course, the rates of occupational injuries, you can see if we compare to the European Union that almost has no columns, it's all the way at the end here, the European Union. We are supposed to be going up and down, but we have problems with data. There are these selected countries where we're supposed to have best data. And occupational diseases, we have, according to our regional survey in 2006, occupational infections, cancer, allergies, mental health and work problems, musculoskeletal disorders, and results of physical hazards like occupational hearing loss. And the rates, look at the ones, just take a guess, which are the European Union? The second column, of course. The rest is us. We estimate that we maybe reach 5% of the reality, maybe, in the whole region. So imagine, we have a very critical problem. This is some of the estimates of WHO. And of course, we're facing, based on the last burden of diseases study that studied clusters of occupational risk, analyzed them, and we have real evidence from them that we have real big problems for premature death attributed to mortality caused by occupational hazards. We have premature disability and death, and we have a package of most preventable exposures to occupational carcinogens, which is another big issue. So we have 2 big epidemics, the old and the new epidemics in occupational diseases, and we have to deal with that too. And some of the things we know is that occupational cancer hazards are there, and we don't look at them. And the trends are increasing. Here's the evidence. And so we have a lot of a mix in there that is really important. But the big conclusion of this part of our review on this is that we have a very severe problem. We have information that is not reliable. We have a variety of sources and quality of data that we cannot compare. Occupational injury rates are very varied. Morbidity is almost inexistent for occupational diseases, and we know we have a big problem. And the average number of days of loss are also different quantifications. And when the workers go to the health system, we have a dilemma. So the walk, very quickly, based on a regional action plan that is interdisciplinary, transnational, intersectorial, and based on human sustainable development. We act with 21 collaborating centers distributed in all the countries, less in South America and Central America, growing though, and most of them in Canada and in the United States, NIOSH being one of them. We work together to trying to make a difference. So what have we done specifically for this informal workers? So we needed to know, to identify who, where, and how are they working, to see if there is research done or ongoing, to seek for interventions and best practices, to validate this information once we gather it, and to make a report. Our consultant was this engineer that has done a very huge work and continues to do it. And what we have found is that we have been able to, right now in the paper, because it's currently being translated to English so we can share it to our partners in English, definitions, the statistics that most of them I showed here, the poverty data, and the population in vulnerability data. Then the research ongoing, we have detected several networks of researchers in South America, but particularly networks in Latin America, and networks of universities that are trying to do to make a difference. I'm going to expand a little bit later. And of course, a systematic review of peer and gray literature. And I'm sorry for the bit of time I'm taking over, but this is very important. In Latin America, I don't know if the other regions have the same problem. We have no culture of publication, of peer review publications. So to get information, we have to knock door to door and look for great literature. It is a pity, yes. We need to improve it, yes. But we have to handle it. We have to lead with it. And this is why one of the things we want to do is to really go on. So seeking for interventions and best practices, we have ongoing practices. You heard about Brazil. I'm not going to repeat. Colombia has done very interesting. Cuba has done very interesting. Mexico, Bolivia, and Central American countries have a very interesting thing. And after putting all this together, we made a small workshop in Cuba. Here are the members of our working group in 2012. And what we looked at was the ecosystemic approach projects with 3 of our collaborating centers and their partners, and that have led to the communities of practice in Central America tackling informal work. In the Indian region, and in Canada, and in Central America. There are 3 big networks of communities of practice. Then we look at the project of PAHO that it's called Faces, Voices, and Places, that it was designed to tackle and measure the Millennium Development Goals, but it worked to detect a lot of poverty, a lot of informal work. So involuntarily, it did serve for a purpose. Then we look at the human security model projects, which are addressed to population in extreme conditions of vulnerability, and found that 5 countries of the region are also having this type of projects. We look at the own account workers in Cuba, because this was a very special case and the needs to improvement. We had a big discussion. It's still on working project. We had the equity, health, and work and health networks, the TEEs of Orient Soral that you heard her presentations, and we have had some very interesting grassroots and cooperative organizations, particularly in Central America, the Association of Rural Workers, los Asociación de Trabajadores del Campo from Nicaragua, that started 15 years with small committees, and now they provide and sell services to their insurance, Social Security Institute of Nicaragua. So this is just an example for Colombia. They started with a policy strategy, and now they went to the practice. And then the conclusions of this workshop was that sustainable development and health in all policies need to work hand in hand and need to address local realities, because definitely not one size fits all. And I think this is broad conclusions for all the presentations I've heard during yesterday and today. Modeling for interventions of occupational health and safety and well-being are alternatives under discussion in the working group, because in the governing bodies of PAHO asked us to address the health of people between 18 and 65 years old in the course of life, and particularly focus on men because they seem also to be invisible for numbers and for statistics. So we're working on that too. Need of total involvement of people, grassroots and cooperatives, and need of partnerships, of course, stakeholders with common goals to improve people's lives and health, and needs to strengthen, and this is also a match, the health sector and the human resources for occupational health and safety. This is the format that we're using for strengthening human resources for health, some of the solutions that have been provided already, and for the future, well, we would like to develop and or strengthen information systems. We need that. This is the first urgent need. We would like to build evidence for national policy on healthcare workers, occupational health, to ensure accessibility to occupational health services, to ensure availability of safe technology, to develop and implement research agendas that fit the needs of these people, and to disseminate and adapt best practices at local level. We would like to change this syndrome that was designed by Maritza, Tennessee in the 90s, and that unfortunately still is ongoing. This is one of our very sad conclusions. And then, of course, towards equity with social justice, we want to improve basic dimensions of human development. We want to overcome deprivation and decreasing poverty indexes. We want to look towards elimination of social exclusion. We want to eliminate gender inequities. We would like to strengthen opportunities for women, and we would like to empower workers in all dimensions with social power and with psychological power. And of course, to have a beautiful worker in a just, perfect working conditions where all his voice and all his interests are tackled. And thank you.